Record. Hello, welcome, ladies and gentlemen. I am Dennis Ferretia. I'm the director of the Center for Multicultural and Global Health, as well as the associate director for the Global Surgery Institute here at the University of Tennessee Health Science Center in Memphis. We are very excited, to be hosting this grand rounds, our monthly grand rounds for the Center for Multicultural and Global Health. This is a monthly event. In addition to our grand rounds, we do have annually an annual symposium, the CMGH annual symposium, our first inaugural being last year in November, which was really kicking off our endeavors in this area. Today, we are very excited to welcome Dr. Jason Brotherton, who is currently in Kenya. We are excited to have you, and I would invite our dear colleague, Dr. Rebecca Garrity, who is a third-year med-peds resident, not surgery resident, med-peds resident here at UT to do the honors. Becca, over to you.
Absolutely. I'll leave all the surgery to you, Dr. Ferretia, but it is our honor to welcome Dr. Jason Brotherton back to UTHSC, all the way from Kijabe, Kenya today. So he is originally from East Tennessee, and he went to medical school here at UTHSC. He then went to the University of Southern California in LA County Medical Center for his med-peds residency. And pretty immediately following that, he committed to a 5-year exchange, if you will, or commitment to the Kijabe Missionary Hospital, where he became their ICU director. And since then, he has grown that program. And then last year, I believe 2020 to 2021, he became the global ICU fellow at the University of Pittsburgh, Department of Critical Care. And he learned a lot more about ICU and is going to talk to us today about building capacity and his kind of journey at Kijabe Mission Hospital in Kenya. So thank you so much for joining us. I know it's late there and we really appreciate your time.
Yeah, no worries. Thank you so very much for this opportunity to talk. I'm really excited. So give me one sec and I'll try to get going here. All right, can everybody see my slides? All right, we got a thumbs up. All right, that's awesome. Okay, hey, Dr. Garrity, if you don't mind, but since I can't see the chat, if you see people that put questions in the chat, just like give me a wave or something and we'll go from there. So the conflict of interest slide that's always there, everything that I'll talk about, are my experiences, and this discussion, will focus on what I have experienced in my particular career. They don't represent Kijabe, Pittsburgh, or the NGO that I work for. I don't have anything to disclose. And all the pictures that you see were taken with patient consent, okay? So through this, ultimately, I hope that you guys will kind of learn from my mistakes, because the title of this is, lifelong unlearning. And I put confessions of a quote unquote global health worker, and I hope that I will effectively convey some of my experiences, and hope that at the end of it, like, we'll all have a better appreciation of global health, and ultimately find meaningful ways to work cross-culturally there in Memphis, or abroad, or anywhere stateside. And then, because it's a new conference and I know some of you will be eating, hopefully you'll remain awake, but if you don't, it's totally fine. You're not going to hurt my feelings. So first and foremost, I have to tell you guys that I have the coolest job on the planet, and I get to work with all these amazing people right here, and just quite frankly, it's a true honor and privilege just to get to work with all these amazing individuals that you can see here. And I don't know, I could go on and on just talking about them, but I'll try not to bore you to death. But like, just as physicians, we have a true privilege to get to care for patients, whether it's domestically, internationally, what have you. So in order to like not make you outrageously bored, I'm going to have a few pictures here. And if you want to unmute yourselves and yell out what it is that you see, we'll go through. But I will tell you that this individual came to our hospital on the back of a picky or a motorcycle. And so this was the first x-ray that we got. And just for the sake of time, I'm sure everyone saw this enormous spear here. And just so you don't think that it's laying on his stomach, it's pretty much right in front of his vertebrae. The most shocking thing about this is when we told him, it's like, excuse me, sir, like you need to be hospitalized and you need to be evaluated by our surgeons. He's like, no, I'm going home. I don't have time for this. And then got back on that same motorcycle and left. And so I wish I could tell you I knew what happened to this individual, but I do not. So just the lifelong learning journey that we are all on. It's more or less defined. I looked up a definition and surprisingly there is. And it's the ongoing pursuit of knowledge for either personal or professional growth. And I think, pursuing medicine, pursuing residency and higher learning fellowship, whatever, we're all committed to that. And then sometimes we'll be relearning things that we've learned before. I can't tell you, I'd probably be embarrassed to tell you the number of times that I've looked up how to manage or work up or diagnose which hyponatremia that I'm dealing with. A lot of times we will be learning new concepts, new technologies, new things, especially as quickly as medicine in high income countries changes. But what I would like to walk you through is a lot of the things that I've had to unlearn that I have brought into this particular context in the short-term trips that I took as a medical student and resident, and now living and working full-time in this particular context. So I think to date this is the only picture of me and a patient, and just to be completely honest, I absolutely hate this photo because it really kind of embodies a lot of the white saviorism that is within this particular context. However, I do keep it to remind me of where this was taken, which was in Sudan in 2006. I had never been out of the country. I grew up in rural Appalachia and had never been out of the country until second year of medical school. And I went with Dr. Novick and Dr. Bugnitz, who is a pediatric critical care physician there that I'm sure the majority of you guys know. And so there's probably not a week that goes by that I don't think back about this particular trip, because I didn't know anything medically. I had never been out of the country, so I knew nothing about the world. And so I was kind of a blank slate from that perspective, because literally I had no idea which way was up. But after going and coming back, I decided that I should probably do med-peds because it was a pediatric focused residency, or excuse me, a pediatric focused trip with Dr. Novick. But for every sick child there, there were parents that needed to be cared for there as well. And so that's kind of what got me on the med-peds path. But for better or for worse, it kind of started to get me thinking. It's like, okay, how am I going to be involved with this? And two, what do I think ignorantly, is the problem, and how do I go about fixing them? And I think, we all kind of want to do something to be involved, but I don't necessarily think that it's our job to try to figure out, what the problem is and how to fix it. And so I look back at this photo and see it as my white privileged self, and continually wrestle with all that moving forward and getting to work in this particular context. And so as Dr. Garrity already said, I went to med school there. I went to residency at LA County, which was a fantastic place to train. I loved it. Med-peds, I would definitely do it again. And so I worked really hard to try to prepare myself to work in an international setting, and trying to learn as much as possible. But along the way, I got to go on a couple of trips, during residency, and then really ultimately based upon now these small aliquots of working cross-culturally, For lack of better words, I started to make assumptions, about my involvement, like, I am needed as an outsider, which is a terrible, terrible perspective. And I will be the first one to tell you that that is an awful perspective. And I've been wrestling with that the entire time. It's like my skills will be appreciated because, as I'll, show here in a little bit, I even went to a hospital where there was no internal medicine or pediatric physician there. And then, just thinking again that like, okay, I'm needed, I'll be appreciated. So everyone will see my expertise and want to learn from me. And like, literally, these are, some of the awful things that I've wrestled with and recognized that like, this is not the perspective of global health. And so I hope that you can see, like this as a confession of, how to not go about that. And really, I showed up with a lot of baggage. I did not know like how prophetic this particular sign would be, at the airport when me and my wife and my son got off the plane 6 years ago with thinking like, how it is that we would be involved. And so I think when we work cross-culturally, because really essentially that's what it is. It's cross-cultural work, because like when I moved from Memphis to Los Angeles, it was a completely different population, a completely different culture, a completely different people group with different determinants, social determinants of health, a different language because the majority of our patients were Spanish speaking. And so it really truly was a cross-cultural experience. And really this is what global health should be called. It's cross-cultural medicine, because like we don't just go somewhere and do medicine, like we go somewhere and try to invest and understand and listen and be a part. And so this is just something that like I learn on a daily basis. And so to use the title of this book, when I initially showed up, I thought that there would be fantastic Great Expectations that I've already gone through. If you've read the book, awesome. If you haven't, this was just, I don't know, a pithy little slide to talk about Great Expectations. But some of the things I've had to unlearn are kind of obvious, right? Some of the medical things, like handling sepsis, which is, the #1 killer in the resource constrained setting and, causes 1 in 5 deaths globally, how we treat it from a pediatric perspective, how we treat it from an adult perspective, showing up and slamming patients with IV fluids via bolus, has been shown in very good randomized control trials that, it is very, very detrimental. So like, picking up a journal, reading, it's like, okay, don't do that. That's fine. But some of the other things, like, in the adage in medicine, if you hear hoofbeats, you think of horses, not zebras. But in Kenya, you would be hard pressed to find a horse. We see all kinds of zebras or zebras, but you'd be hard pressed to find a horse. Maybe a punda is what is the Swahili word for donkey. But having to get past that or saying that on rounds, it kind of falls flat from as an empty platitude, right? One of the other things, I've kind of alluded to is like, showing up as the American doctor and trying to be, Captain America, which whenever I get agitated or frustrated or, whatever, my wife says, you're being Captain America again, which is her way of saying, calm down and relax and or stop, be culturally appropriate, stop being a jerk. And so trying to really just like take off the lens that I would look through as a Westerner and, take up the lens of, a local clinician here in Kenya. And a very poignant example that I have is it was my first week. I did Swahili for three months, which is definitely not enough to learn Swahili, but it was enough to make me dangerous, and enough to where all the medical officers laughed at my Swahili, which was awesome in and of itself. But it was my first week, and we had morning reports, and they were presenting a case of a woman that had been it was a domestic abuse case, essentially, because they had talked about how she was essentially beaten and brought into the hospital. And so I waited to get through. They went through the whole thing. They were talking about their plan, and I was like, okay. And they were like, okay, so Mrs. So-and-so is going to go home. And I'm like, so where's the husband? Did he get arrested? And then like a couple people kind of looked weird and, you know, kind of laughed. And I was like, so we're not going to send her home to where he is, right? And they're like, well, yes, that's her house. That's where she's going. And I was like, well, what's going to prevent this from happening again? Or, you know, worst case scenario, she shows up dead in our casualty, right? And me got very Captain American, very indignant about the situation. And then I get, thankfully, because like I said, I was so new and so young at this. Basically, someone sat me down and did like, look, this is the situation. She is married to her husband. Her family has paid the dowry, or excuse me, her husband has paid the dowry to the family. That money has been spent on, you know, making ends meet. So therefore, for lack of better words, no matter how you feel about it, like she is his, and she is his financial life support. And, you know, like if she leaves him, then, you know, she'll be cut off from her family, she'll be cut off from him, and then she and her children will suffer, you know, significant social and possible economic ramifications. And I was just completely blown away, because like I was so ignorant to the entire thing. And, you know, like that's just a very poignant example, like I said, of how it is that, you know, I've started my unlearning process. Another unlearning thing is that, you know, some of you may know back in 2017, there was this massive governmental strike here in Kenya. It lasted 100 days. And so every single government employed physician, be they a medical officer intern or a medical officer or a consultant, went home. And so all the government facilities closed, which means that the only hospitals left were the private hospitals in Nairobi, which are, you know, some are very good hospitals, but they're far outside of the price range for many Kenyans. And so the mission hospitals were kind of left, and like, you know, we're exploding and bursting at the seams, and running at 110, 120% capacity, trying to do what we can do. And so my idea of getting to show up and teach just got, you know, the rug completely jerked out from under, because all of the people that I was there to teach left. And so the clinical officers, which are the equivalent to nurse practitioners and PAs in the US, they 9 times out of 10 do not get paid by the hospitals, but they're required to do an internship. So essentially, me and 2 clinical officers rounded on the internal medicine and pediatric patients for 100 straight days. And it was a learning and unlearning experience all the same. And so I was kind of flabbergasted about the strike. But again, it's another thing that like I don't understand at all, and didn't understand at the time. So one of the other things to consider, and one of the other unlearnings that I did when I was an intern at the Los Angeles County Hospital, the very first thing that we learned, like we had to do BLS, ACLS, and PALS, and NRP because I was med-peds. And so when I showed up, someone had just donated a defibrillator. And so CPR had not been taught at the first hospital where I worked, which was Kijabe Hospital. We were there for about 3 years. And so we're like, okay, we have this new machine. We're going to teach BLS, ACLS, all that stuff. And what we thought was a really good idea turned out to be an interesting idea, because in a lot of times, you know, in the Western context, we have discussions with the family and tell them it's like, you know, care is futile if the heart stops. There's nothing that we're going to be able to do to get them back to a meaningful life. We tried to have that particular conversation here, but it didn't always work. And so they were resuscitating and doing CPR on everyone from like 9 minutes of age to 109 years of age, regardless of what the outcome was going to be. And I asked one of the nurses, is like, you know, what, why are we, like, help me understand why we're doing this. And she was one of the more seasoned nurses, and thankfully she saw basically how dumb I was, and she's like, okay, I'm going to help you. And so she was kind of my cultural go-between, and so she's like, look, culturally, we cannot do something for someone laying in this bed and not turn around and do it for someone laying in that bed. And so even though medically we know that, like, chest compressions in some contexts could be considered absolute torture to someone with, that it's not going to improve their outcome, culturally, my perspective was completely wrong. And so, again, another unlearning opportunity. This one I thought this is going to be a great idea because we had so many children that were presenting to our hospital with severe acute malnutrition. We had a nutritionist at the hospital. I was like, we should be measuring the MUOC and calculating their Z-score and diagnosing them with malnutrition and then plugging them into our nutrition clinic. So we peeled through hundreds and hundreds of charts and found all kinds of kids that, we had missed. And so we tried to implement and getting it going forward. And we looked again and we found out that, like, no one was being diagnosed with malnutrition. No one was going to clinic. And so I talked to the nutritionist and I was like, I know we're having kids that are malnourished. Like, what gives? And she's like, Dr. when you say these kids are malnourished, it is an absolute affront to the mother's ability to take care of their kid. And she's like, they don't want to be diagnosed with malnutrition, even if it meant that they were getting extra services, because, like, they would get to go to the malnutrition clinic and have conversations with Sylvia. They're like, they don't want to do it because, like, it means that they are not able to care for their child. And again, this is all things that, like, are not in global health textbooks. And the people that I talked to about global health before, I got on the plane, nobody told me about all this stuff. And so literally it's been just like peeling back layers of onions the entire time to try to understand what on earth it is that I'm doing here. And, like, how can I be an effective colleague and an effective member of the community and not just somebody that runs around ranting all the time. Outside hospital, oh man, it's a 4-letter word. So I can't tell you how many times we said it as a resident. It's like, oh, they got transferred from outside hospital, blah, 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 blah. I have so much more respect now for the community workers in the outside hospital because, like, I have been outside hospital for 3 years. Like, even here in Kenya, trying to transfer someone from the remote hospital in Chogoria down to Nairobi, just the conversations that were on the phone and the, well, why are you not doing X or why did you not do Y? And I'm like, we don't have either one of those. And so it definitely has given me a tremendous amount of respect, even there in the States when, thinking back as a resident and even chief resident, it's like, oh man, they came from community hospital, X or whatever. So really, the things that I've been touching on have been my unlearning, and a lot of them have been areas where there's been friction between my values, as a Westerner, as a white Westerner, as a white male Westerner, based upon my culture and, showing up in where I am a visitor and trying to see how I can effectively be a member of the community, looking at the values of the community and their culture. And, a lot of times there's a lot of friction. And, this picture is very representative because, like, a lot of these relationships and a lot of these things are under a tremendous amount of tension and are really just hanging on, by a thread. And, I talked about the one with domestic abuse, but for the sake of time, I won't go through others. But I mean, there are just so many difficult things to where, if we look at it through our Captain America lens, then we're going to get frustrated. We're going to get burned out. We're going to get really upset. And we're going to be disrespectful as visitors in our particular context to the men and women that are, have been here long before we ever decided to come here and will continue to be here whenever we go home. And so, I ask myself, like, am I right? Are they right? Ultimately, I've come to the conclusion, like, it doesn't matter. I am a visitor, and, like, there are areas of discussion in and amongst a lot of these things, but ultimately it's, my job to be respectful of the local culture and really to try to do my best to understand it. And so I think ultimately, over the 6 years that I've been here, the black and white things that I had in my mind before I left are definitely not black and white anymore. And there's just so many iterations of gray. And like, frankly, I had to rethink about what global health was for me. Before it's like, okay, I'm going to go, I'm going to work, I'm going to care for patients, and if there are people to teach along the way, awesome. But this is a picture from the WHO that you can find this online. The website's there below, but it'll tell you basically how many physicians there are per thousand people in the country. And Kenya is 1.57. The WHO index is about 4.5. Cuba is the best at 80, just over 84 per thousand population. The US overall has about 26. I think the best one in US is the best city in the US is Boston. There are like 300 or so clinicians or physicians per 1,000 patients. So, all right, picture time. This was a young boy that came to us. Ultimately, some swelling, a big scab. I'll give you a small hint. And when we were asking him, he's like, what have you been doing? And he's like, oh, I was helping my uncle with goat hides, cleaning them and then selling them. So anyone want to yell out what they think this might be?
Anthrax.
Yeah, anthrax. Good job. So we gave him a little bit of penicillin and some clindamycin, and literally in 3 or 4 days, the swelling went down. He can open up the eye and he's happy again. So TARP, this picture. This is where I am now. This is Kijabe. Full disclosure, it's illegal to have a drone in the country, but someone had one and got this beautiful picture. So this is where I spend all my time now. Let's see. Right there is the hospital proper, and this is Bethany Kids, where the pediatric hospital is and where the pediatric surgeons are. That is Cure International, which is an international nonprofit that does orthopedic surgery for children kind of all over the world. Let's see, that is our the Kijabe College of Health Sciences that has a nursing school in it and has the clinical officer school that I'll talk about here shortly. My house is back that way a little bit. It's only a 4-minute walk, so my commute is pretty awesome. That is the Great Rift Valley, and that is Mount Longonot, which is a volcano that last erupted like back in the 1800s. And you can actually hike it. So it's only like a 20-25 minute drive, but it gets up to about 11,000 feet. So it's a pretty awesome hike. So the majority of my time now is teaching, and this is the time where I get to learn a lot from all of my colleagues. And so this is the inaugural class of the Family Medicine Residency Program through Kabarak University. In this picture, 3 countries are represented. We have learners from Kenya, Burundi, and Congo. Not in this picture are 3 residents from 3 other countries, Uganda, Tanzania, and Ethiopia. All of these guys have since graduated because they were the inaugural class back in 2016. But it is not infrequent that I still don't get messages from them, just to say hey, or to like talk through a case. And what's been really cool is whenever, and some of you that are, maybe attendings or even senior residents and seeing medical students grow, is like the first conversations that we had back in 2016, 2017 is kind of like, okay, this is the history, the fiscal, the labs, what should I do to, okay, this is what I want to do. And, there's a little bit of, okay, well, maybe consider this, maybe consider that, to now it's like, this is what I've got, this is what I'm doing. I'm like, I have nothing to add. That's perfect. That's awesome. And so it's been really cool to be a part of this, to see these clinicians grow. One of the other programs that I get to teach in is the only pediatric emergency and critical care fellowship on the continent outside of South Africa. So literally there's nothing between South Africa and where we are up in East Africa. And we have fellows from here in Kenya, Uganda, Tanzania, Ghana, Rwanda. So this is another fantastic place that we're able to, be involved in and help teach and really do some capacity building. But if I told you that I only teach, physicians, then that would be a lie. And it also would really be overlooking the backbone of sub-Saharan Africa and especially East Africa. For example, here in Kenya, clinical officers that I mentioned are the mid-level providers. They outnumber physicians 4 to 1. And they are definitely dispersed all over the country in more rural areas where they're definitely needed. Here are a class of, we call them ECHOs. It's Emergency Critical Care Clinical Officer Program. And so after they've done their clinical officer training, we do 18 months of kind of intensive emergency medicine and critical care training to where they learn trauma care, they learn ACLS and BLS, they learn ATLS, they learn some POCUS skills that you can see there. So these guys have been dispersed all over the country, from all the way up in Turkana to the coast of Mombasa and Garissa. I think out of the 40 or so that have graduated in the last, since the program started in 2017, one is in Nairobi, and all the rest are kind of dispersed elsewhere. And so some of the other, non-physician or clinician programs that we have here, clearly there's the nurses that we get to teach every day at the bedside. There are KRNAs, the Kenya Registered Nurse Anesthetist Program, and they rotate through the ICU with us, but we also get to teach them, critical care, but they also, get to learn anesthesia because, anesthesia care is tremendously important. And I think, I don't remember the journal, but it is not in the too distant past to where, they had discussed that perioperative complication and perioperative death actually outnumbers the deaths due to HIV, TB, and malaria combined. And so, trying to improve perioperative care is another tremendous way to improve health in these particular contexts. So a lot of what we do is, as I've tried to outline, is, we try to partner locally and, just basically walk alongside whatever is already here, or, try to grow capacity from an educational standpoint. However, we've definitely seen this throughout the pandemic, but even beforehand, nurses especially get poached all the time from, the UK, the US. And, in a lot of ways, it's difficult to say, they shouldn't be doing that, the men and women nurses that do that, because they're essentially doing everything that we always do, which is try to provide a better life for their family and do all the things that each one of us try to do. It basically steps in. This article is from the New York Times. Literally, it was just published 2 days ago. So I think the pandemic has shown a light on many things within global health, but not the least of which is, what we would consider brain drain. But what I would posit is that brain drain is not a moving from a resource constrained to a resource unconstrained area or low income, high income, whatever. Brain drain occurs within particular countries, and like it happens here in Kenya, to where the majority, so for example, Nairobi has 8% of the population. There are almost 54 million people that live in Kenya, and 8% of the population is in Nairobi. But over 30% of the doctors in Kenya are located in Nairobi. And so it basically puts a huge strain and burden on the district hospitals that are, doing their best to care for the majority of Kenyans. And so that also, I don't think Kenya is unique in that particular context. But again, economic opportunity is in the urban setting. Educational opportunity for the physician's children is in the urban setting. And so I think a tremendously overlooked aspect of global health, if you will, is yes, we're trying to build capacity and build good training programs. So it's not necessary to travel to the UK or to the US to gain training. But we also need to like look at the other, the other components of the decision making for why people move, right? I mean, because like all of us have been able to take advantage of the educational system in one way or another. And all of my colleagues here in Kenya, be they from Kenya or not, are trying to do the exact same thing for their children. And so I think being creative and thinking about that, or is outside of the scope of this conversation, and probably outside the scope of us as physicians. But I really think it's an untapped area for us to to try to keep local talent for extended periods of time, in these neglected areas. Any thoughts on these two young ladies?
Neurofibromas?
And neither of them had a diagnosis until they came to our
Angiofibromas
hospital. I'm sorry?
Like angiofibromas or neurofibromas?
Yes. So the neurofibromas are on the right. So that lady had neurofibromatosis, and the young lady on these are two separate patients, by the way, in case that's not obvious. And then the lady on the left has tuberous sclerosis. So neither one of them were aware of their diagnosis and until then. So good job. That was awesome. And you guys are making my pictures look too easy. I'll have to get tougher ones next time. One other area of unlearning, and so I already talked about, the HIV, TB, or whatnot, is like there are a lot of silos in global health. And so, there's been tons and tons of money put in to the communicable diseases, but like, honestly, the non-communicable diseases are becoming more and more prevalent, especially in Kenya, because like there is a burgeoning middle class, and people are living longer. Like I remember specifically, I was outrageously excited one day on rounds. We had a woman that was on the ward, and she was like 94 years old. And like the intern finished presenting, and then I was like, how awesome is it that we're getting to care for a 94-year-old woman? Because like it wasn't very long ago that the median life expectancy for a female was under 60 in this particular country. And like in a short period, we have a number, the median age of our ward is well above that now. And so I think getting away from, just thinking about the sexiness of HIV, TB, and malaria, and where all the money goes, and really start to think about, other things to grow the capacity to care for patients with, with some of these non-communicable diseases, and getting out of the silos. Ultimately, a lot of global health is missed opportunity, and not, HIV, TB, and malaria. And this is a patient that we had last month in our hospital that was 18 years old and had never gotten a diagnosis. She basically had 18 years of abdominal distension and never got a diagnosis until she was came to our hospital. For time's sake, because I see that I might run out of time. So she was 18 and diagnosed with Hirschsprung's. We thought maybe it was going to be SIPO, but it was Hirschsprung's. She had she got a biopsy. There were no ganglionic cells. So then she ended up getting her ostomy, and we are working on trying to improve her nutrition. Thinking about research in this particular context can be exciting, interesting at best. So this is the medical records department. Before we implemented, we got an electronic medical record system. So you can imagine trying to do a retrospective or some sort of quality improvement study trying to get through this. But you can also think about a lot of the randomized control trials are done in high-income settings on high-income patients, and are not generalizable to this particular setting on so many levels. And so one of the wonderful things about this is that, this place is ripe for doing research. There's so many people that are interested. The bad part about it is a lot of people are doing it poorly. meaning, there's the parachute research, the helicopter research, the in and out, however it is you want to call it. And, there are papers without local authors, and I don't consider myself a local author. I live here, I work here, I am not Kenyan, so I do not consider myself a local author. And I've had arguments about that even with people here. But local authors, look like Evelyn, who is the medical director and internist at our hospital, and George, who is an internist at our hospital that's in the middle of doing his cardiology fellowship. Like, these are amazing and brilliant people that are super interested in research, but for lack of better words, they're tremendously brilliant people, and then so they start to get administrative duties, and it makes it very, very difficult on them to to be a part of the research. And so trying to be creative on how to get them involved and keep them involved, but not chewing up all 24 hours a day of their time can be difficult. All right, I think this one might take you longer than 5 seconds to diagnose. So this is an elderly gentleman that came for the rash, but on further questioning, he said, yeah, maybe I've had some diarrhea. And then his spouse is like, he's a little forgetful sometimes too. Any guesses? 3, 2.
Is it porphyria?
Close, pellagra. So dermatitis, diarrhea, dementia. So yeah, so we tried to rule out all the other things. We gave him a truckload full of niacin to go home with. I never saw him again. But like, he didn't have the other things that would cause like the photosensitivity. He wasn't on any drugs like hydrochlorothiazide, sulfonamides, or anything like that. And it didn't have like the photodermatitis from like messing with citrus fruits or anything like that. So yeah, so we think he had a pretty significant niacin deficiency due to pellagra. So as Dr. Garrity talked about, so I am the Global Health Fellow. Don't get very impressed about that. It's just a title. I might make myself a sash just for fun later. But I've always enjoyed critical care in medical school and residency, and I loved, grew to love global health, but I had no idea like, how am I going to marry these two things? And so I was like, you know what, I'll put critical care aside, and if it comes back up, great, but otherwise I think we should go and serve in work. And so we did that, but soon I learned that like, despite there not being a intensive care unit, if you will, at the hospital that I worked, we took care of critically ill patients all day, every day with minimal resources. In Kenya specifically, there are 10 critical care trained physicians. All of them are anesthesia. 8 out of the 10 are in Nairobi. One's in Mombasa, one is in Eldoret at MTRH. And so all 10 of them had to go to the UK for training. So you can imagine being an anesthesia critical care trained individual. It's like, well, if I'm in the ICU, I'm not in theater. If I'm not in theater, if I'm in theater, I'm not in ICU. I did get the title of the critical ICU director here at Kijabe Hospital. That just meant that I was the most interested person. And like, again, that had absolutely nothing to do with me. But ultimately, I was like, okay, I really need to upskill myself because one, I'm taking care of critically ill patients, and like, they deserve somebody that has skills other than just like frantically trying to read stuff all the time to figure out what's going on. Like, they deserve someone who knows more about critical care. And then all of the learners that I've talked about that rotate through our ICU, like, they deserve too someone that like has some knowledge, some wisdom, some experience in doing that as well. And so I went back from July 20 to June 21, got to work in Pittsburgh during the pandemic, and then have been back here since, trying to impart some of what it is that I learned in this time. Being before going and seeing the pandemic start in the US, and seeing all of the clinicians, that your colleagues, your co-residents, whatnot, struggling with what do we do whenever we've exceeded the capacity of our health system, and talking about, we were going to run out of vents and this, that, and the other. It was very interesting from this particular perspective to see the U.S. struggle while being here in Kenya. And, because it's literally something that we talk about and struggle with every single day. Kenya has 254 mechanical ventilators in it. University of Pittsburgh, where I am a fellow, in 2 of the hospitals, there are more than 250 vents. Okay, so like, just to put that into perspective, I mean, I'm sure that like there are more vents than that between the Med, Methodist, Baptist, Laban or whatever. And so really just thinking about that is kind of mind-blowing. I mean, even today, I had to have the conversation because we accepted a patient that is going to have a subdural evacuated, and we had 1 bed left with 1 vent in the ICU left. And I was like, we usually don't give away our very last bed to an outside transfer, because what happens if someone comes through casualty or, whatever. So like, having these conversations on a daily basis can be tough. And, there've been lots of times that I felt like, man, we definitely made the wrong decision, or I hope we made the right decision. And so, like, that's another one of those things that doesn't get talked about very much, within global health is, sometimes you can call it moral injury or what have you, but, these decisions are very, very significant, and they, can weigh on you over time. It was difficult being away back in Pittsburgh because Kenya did not have a significant number of cases until what they'll call like the 4th wave, which just happened in May and June. We expected there to be landfall basically at some point in time because of the amount of respiratory illness that's already here with TB, COPD, things like that. But thankfully, it never came. But I have this picture here to kind of discuss the duality theme that's in this novel of it kind of became like a tale of 2 COVIDs in a lot of ways. And has the irony of that has not been lost on me because, working with the COVID patients here in Kenya, working with COVID patients there in the US, and like, it's obvious to think about that there's a huge disparity in resource and whatnot and outcome. But, one of the things that you didn't necessarily think that there would be a tremendous amount of difference was like access to vaccination. And I mean, like the majority of you, I was incredibly stoked to get my immunization. Although it was with a little bit of guilt because I was like, man, how long is it going to be before my colleagues in Kenya can get their shot? And I mean, I thought, oh, maybe it'd be a few months because like, COVAX is pre-purchased all these and, this, that, and the other. And like, it's a global pandemic and, all these places about global health, blah, 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 blah. But, is another area of unlearning is like, man, is kind of appalling to see that like even now today, only about 15% of Kenyans, adult aged Kenyans are fully vaccinated. And so, I mean, we're 3 years into the pandemic. I got my first shot 14 months ago. So, I mean, it's tremendous. And like, if you want to read more about like, vaccine apartheid, vaccine inequity, there are lots of people that are writing tremendously thoughtful pieces on it. And, I would encourage you, to look at those, to think about it, from a global health perspective. Thinking about the purchase of the vaccinations, this is from The Guardian, just to not bore you, but so Canada purchased 9 vaccines per citizen. The US about 4, the UK 5 per citizen. And so you can see here that the African Union was able to purchase 0.2 per citizen. And so, I mean, it's just horrific, like how nationalism has seeped into global health, and to see, to see something like this. And the majority of those like extra vaccines that were purchased from Canada, US, and the UK were from COVAX, which was, designed to try to get these vaccinations to low and middle income countries. And, And this was just from a few days ago. Oh yeah, it's from the 19th. So the Gavi's like, we basically don't have any more money. One of the other inequities of the pandemic is ultimately just the cost. So tocilizumab used on severely ill patients in COVID, you guys know all that stuff, so I'm not going to bore you with that. But the cost to get this is $1,800 US, which is 1.8 million keys, 1.8 million shillings, $1,800 US. The gross national income per capita in Kenya is $1,700 US. So, I mean, like one vial of this is more than an entire year's income, for individuals. And so, trying to get these things, even if we can, is like untenable from a perspective of being able for patients to be able to pay for it. Thankfully, though, baricitinib is about $65 US, because I guess it's in pill form and not IV, and not as fun to say as tocilizumab, but. So I've been caring for ICU patients on both sides of the Atlantic, and on the left is both of these patients are women that I took care of. Both of them were pregnant and had their babies delivered, and then suffered tremendous effects of the coronavirus. The one on the left is on VV ECMO. They're clearly intubated. You can see the pumps back there. The one on the right needed would have gotten ECMO in a situation to where they needed ECMO, but you can see that we prone them. You can see the donated ventilator there, but I mean, there's just a vast difference in these two situations and setups for the exact same disease. Because we don't have those fancy pink pads that you prone people on to protect their joints. These are gloves filled with water that we put under like the pressure points, and they work wonderfully. The nurses thought I was a bit crazy in trying to put these things together, but they worked. So I guess that's the bright spot, but it is difficult to, kind of straddling the pond and being in both of these situations. So moving forward, I've talked about a lot of my unlearning. I've talked about, what it is that I've been doing. I've talked about my experience with critical care. I think the last couple things is all of you are interested in global health, and you have a community there, a group there, a diverse individual with diverse experiences. This was not available in Memphis whenever I was there. I would have loved if, this were available there. So I'm really excited to hear that it's up and running. Some other individuals that I think are good to listen to or follow. So Dr. Pai is an infectious disease doctor in Canada, who has written a lot, perspective and scientific papers just about global health in general. But he's taken the time to curate this website with like 300 books and 200 films on global health. And, these are not the books that romanticize working in the bush and, all that silly stuff. Like, these are books written by local authors that talk about colonization and that talk about their experience, with missionaries, their experience with global health workers. And I think it's good for us, from people from high income contexts, to read those and to listen to some of that, just to get a different perspective of what it's about. And so some of them are directly medical, some of them are just local literature books that talk about the culture and are fantastic. I refused to be on Twitter for the longest time, and then I got on, but it can be a great place to waste your time. But there are a tremendous number of people in quote unquote med Twitter that are like making information so easily accessible, and whether it's global health or internal medicine or pediatrics or global surgery or whatever, I mean, there are so many people that have useful information. And if you can, sift through the crap and like, follow the people that are worth following, and really learn and glean from them. And, I mean, that's how I found Dr. Pai and, Dr. Ambiola, which is one of the editors for BMJ Global Health. And so these are individuals that like, I've never met, but like, I've read their papers, their articles, their, whatever, and have learned a tremendous amount, from them. So I think, finishing up, we're all on this journey of lifelong learning. And so I would just encourage you guys to continue to do the great job that you're doing. And whatever it is you decide to do, wherever it is you decide to do it, the world needs fantastic physicians in all corners of the earth. And so I would encourage you in that, whether it's urology, neurosurgery, internal medicine, family medicine, whatever, like the world needs good doctors in general and people that care about other people. And so I will, I guess, stop rambling and then try to answer or respond to any questions as best I can.
Thank you very much, Dr. Brotherton. That was really amazing, and so many questions. But I would open it up for anyone, comments, concerns, questions. Please just raise your hand or unmute your mic and speak up.
I've got a question, Dr. Brotherton. So first of all, I got to spend a month in Kijabe in 2013 as a med-peds resident, and really loved it. So I'm really happy to have you. Wanted to ask you, mentioned a lot of things about just culturally, the things that you face and the unlearning you've had to do. Do you think in a global health track, is there something we can do to prepare ourselves before we go live or work abroad that'll get us ready for that kind of unlearning process? Or is it something that you just have to experience and learn on in person?
Yeah, I think the short answer is all of us need to find ways to be involved locally, because it just seems completely silly to say, I'm going to go across the world and do X, Y, or Z, but, like I'm not willing to go across the street to understand, the person over there. And so I think finding ways to be involved, there in Memphis, or wherever it is that you end up, if it's still in the US, finding ways to be involved, and find ways to be involved cross-culturally. Like, yeah. I feel like that, if you're not kind of making yourself uncomfortable in a lot of ways, then you're not really pushing yourself and you're not learning, right? And so, whether it's someone, just doing things to try to get, to not insert yourself, because then that brings in a whole big bunch of issues that I'm trying to get on. But like, if you can find ways to be involved in a healthy and meaningful way, in a cross-cultural sense, I think that's a really good start. And then reading about the place that you're going, and not just like, okay, well, schistosomiasis is really common there. And read some cultural books, read the news, written by someone else, by a non-Westerner. And so, trying to put a finger on the pulse as best you can. And then ultimately the rest of it's a choose your own adventure, and you do a lot of learn by doing and a lot of fail by doing. But hopefully you'll have the experience that I have had, and had a lot of graceful people around you that, have forgiven the many times that I've screwed up in this particular context.
Right. Thank you. Yeah, we've our global health track has partnered with some local refugee organizations. So hopefully we are getting some of that local experience as well. So that's great. All right, I'll stop talking.
Other questions? Please unmute and just speak up. Okay, Jason, quickly, regarding, you talked about like the whole issue at the beginning of the talk on the quote unquote white savior complex and the unlearning that you had to, by being there, by understanding the dynamics and respecting, the choices or so that, those physicians have had to or do make in the context in which they find themselves. Can you talk a little bit as to how that component of global health we can further like express or train or teach or communicate apart from what is being done currently with your experience? What would you suggest?
Yeah, that is huge, and I'm not going to pretend like I have all the answers for that, because 6 years in, and I still wrestle with a lot of those things. And so I think first and foremost, recognizing your particular station in life, and whether in where you are born, what your cultural context is, and then if you decide going cross culturally, understanding that your culture is not the right culture, their culture is not the wrong culture. And then, as a white male, recognizing that there have been things put in place or things afoot long before I got here. And another example, just real quick, this happened 2 weeks ago. A patient was in our ICU. They were incredibly sick. They had, metastatic cancer. They became septic, blah, blah. I mean, their chance of survival was nil. And so one of our very well-respected and outrageously brilliant echoes that, probably knows more about critical care in this particular context than I do, is like, I need you to come talk to the family. And it's like, well, you took care of them. You know it, like, you can talk to them. And he's like, no. Like, they're going to ask me and they're going to drill me about why it is they died. You're white, they'll just accept it. And so, just recognizing the privilege that I carry because of the color of my skin, and wrestling with that, and it has absolutely nothing to do with me. I mean, literally, like I said, this just happened 2 weeks ago, right? And so still, I've been here for 6 weeks, and I'm just completely floored by that, because Benjamin could have had that conversation. He would have said the exact same things that I did, but because of the history of colonialism and all of those things that have been set in play long before I got here, or any of us get here, recognizing that, and really just speaking to it and addressing it. I was thinking about it earlier. It's saying I don't see colony is like saying I don't see color, which means you're completely ignoring and disrespecting the experience of the population, the individual, and really it's just blind and deaf and incredibly disrespectful. So that was probably a long-winded answer, but I think just recognizing our particular station and trying to take off our cultural lens and doing our best to put on our home culture lens, and put on the lens of the community that we're there to try to be a part of, not direct or help or show them the way, because us taking that perspective is also incredibly disrespectful and unhealthy as well.
Thank you very much for that. Becca, comments and closing.
Yeah, I have just a comment and a question. I think you're such a beautiful example of, and your talk, the title of the talk, continual unlearning or lifelong unlearning, is such a great example of the posture we should take to all medical encounters, right? Every person really might have a different culture than us, even if it's a white man laying in a bed and I'm a white doctor taking care of them, coming at it humbly and learning their story and learning their perspective is something we should do. And it's even more important in the cross-cultural and cross-continental interactions that we all hope to engage in as global health physicians. From the resident perspective, and some of my co-residents are still here, taking that jump and deciding I'm going to go be a global health physician, and how, where, and how do you have any, advice in what to look for in opportunities and where to look for opportunities for those of us who might want to do it either in a short-term or a long-term fashion?
Yeah, there are various opportunities from non-governmental organizations, private organizations, mission or faith-based organizations. So that's probably one of the first steps in deciding like how it is that you would like to get involved. And then I think one of the biggest things is figuring out how, regardless of the organization, how did that organization find themselves there, right? Do they just, kind of insert themselves and show up and be like, oh, like this is a problem that you have and let me tell you how to fix it. Or, was it an organization that through relationship, kind of proved their worth a little bit and then were invited in and have assimilated into or tried to assimilate into the culture, because I definitely think that's one of the biggest things about deciding what organization to go with. All of them have great things and awful things about them, and those that are trying to figure out how to work themselves out of a job, essentially, because like in the ideal situation, global health just becomes health, right? And so I think organizations that are getting to that or working towards that, are probably good organizations that you'd want to be a part of.
Well,
Go ahead.
thank you so much for being here today. From, starting here at UTHSC, it really gives us perspective of where we can go and the impact that you can have or the impact that you can help have, I think is probably more appropriate in global settings. And we are really excited that we've been able to reach out to you. And for those of you who don't know, he's sent me ideas for simulation topics. He's going to be a really great resource if you don't mind us continuing to use you, Dr. Brotherton, to increase our global health knowledge here.
No, it would be my pleasure to be involved in any way that you think will be useful. So I really appreciate the time, and this was fantastic. Thank you guys so much for the invite. I really, truly appreciate it.
Absolutely. Well, y'all, we're going to have another grand rounds next month. Dr. Brotherton, you're UT fam, so you're always welcome. We'll make sure you're on the listserv and get the invitations, but there'll be another grand rounds probably in about a month from now. I think Dr. Tessima Salam is going to be in charge of inviting our guests for that. So we're really excited. Y'all have a great week, okay?
Thank you all, and
Thank you so
please
much.
look out for this. And Dr. Brotherton, thank you very much again.
Oh, my pleasure. Thank you so much.
Bye, y'all.
Y'all have a great day.